panel, are we? All right, so we're going to hold off to start the lecture for about 5 more minutes. But while we're waiting, obviously the practice question has been up since then, the practice quiz. And I have initially received a question about differentiating between the amygdala and the hippocampus on singular coronal images. So what I'm going to do is pull up the PowerPoint from the second lab. Now, unfortunately, there wasn't a way to embed this in the actual PDF. It's a 3D model, but we've got this 3D model that we can use. And if you want to look at these, then you can find them using a site called oh man, what's the site called? I've lost it. I'll tell you what, I can actually embed these. I can embed these into the course materials. So I'm going to do that. But this 3D model, what we have is the outline of the lateral ventricle in light blue. We can see that caudate in red swooping around. So the caudate, the tail of the caudate is superior to that inferior horn of the lateral ventricle. But anterior to that tail is this large red area, which is the amygdala. And we can also see this rough shape of the hippocampus. So I completely understand. It's pretty difficult to differentiate the amygdala and hippocampus on singular coronal images, but there is a subtlety in their difference of position. So if we stop this share and then jump to a different camera, then what we can do is look really close up at what we'd expect in an inferior horn of that lateral ventricle. So we've got inferior horn of the lateral ventricle. The amygdala is going to be located superior and medial. So let's say this is the left. So we've got medial and lateral. The amygdala is going to be located superior and medial to it. So there's the amygdala. Whereas the hippocampus is going to be located inferior to the inferior horn of the lateral ventricle. We can circle back and jump back to a normal camera and go to the power. This going again. Actually, yeah. And so on here, we've got some coronal images. So let's start this off. So there's a little bit of that inferior horn of the lateral ventricle. And inferior to it is going to be the hippocampus. Superior to it is going to be the amygdala. All right. Got a couple of minutes before we're going to kick off properly. But if you guys have any other questions about the practice quiz, I'm happy to answer those quite briefly. The lecture itself is going to be looking at some dynamic images, which I'm really excited for. That being said, I don't know how long this is going to take, whether this is just going to be about an hour or whether we're going to go to the full 2 hours. I am relatively confident that I could talk indefinitely about these scans because there's just more and more you can unpack on them. But hopefully we won't drag on too long. So let's get stuck in. Just going to cancel my camera because I know that covers the recording somewhat, but we do need to share. I wonder if that's going to change. Share this. Okay, let's pull this out of the way and bring up the chat. Where's that chat gone? There. All right, so what we're looking at is a CT scan of the head. And this is a multiplanar reference. So we've got all three planes, got an axial plane, a sagittal, and a coronal. And we can play around with these and make whatever one we so choose our primary focus. But what we're initially going to do, since this is an ICT, is look at our bony foramina. So if we put this on a coronal, I want to look at those bony foramen and bony structures going from lateral to medial. Okay, so we're starting off with that temporal lobe, and the first structure we can see here are these mastoid air cells. Okay, so we've got the mastoid process, which is somewhat cavitated by these holes, these mastoid air cells that communicate with the middle ear. This here is going to be the zygomatic process of the temporal bone, which will meet the temporal process of the zygomatic bone. And then what we're starting to see is the condyle or head of the mandible. So where it's articulating that temporomandibular joint, and this hypointense region is going to be that external auditory meatus. Now, since this is the mastoid, medial and anterior to the mastoid is going to be this styloid process. Okay, and remember, recall that between the mastoid and the styloid process is the stylomastoid foramen. So we are shortly going to see, if I've gone past it, small stylomastoid foramen. And so this is going to be where the facial nerve exits the skull. But coming back. So we're coming back laterally here. If you're ever lost, you can look at these markers, and it'll tell us where we are. Okay, but we've got mandible, ramus, coronoid process. And as we continue medially, we've got this nice pairing. Okay, so what we're looking at is the internal jugular vein coming out of the skull, so the sigmoid sinus exiting the skull through the jugular foramen, immediately posterior to the internal carotid entering the skull. So since those structures course with each other in the neck, it makes sense that they are associated, tightly associated at the base of the skull. So we've got jugular foramen. And if we move a little bit more laterally, just above the jugular foramen, you can see that internal auditory meatus. Internal auditory meatus. Okay. Jugular foramen. This is the internal carotid coursing through the petrous temporal bone. I'm going to focus on this. And now we've got no bone underneath the internal carotid here. So we're looking at foramen lacerum. And immediately after that, the internal carotid rather, is going to ascend in its cavernous portion. This is the sinus, or rather the carotid siphon within the cavernous sinus. So as we approach that midline, we're going to start to see carotid, but pituitary. Pituitary in that sella turcica, dorsum sellae with the clivus, and posterior and anterior clinoid processes. Okay, we're going to jump back lateral and make our way back medially, looking more in that posterior cranial fossa again. So jugular foramen. You can see the hypoglossal canal here in the anterior and lateral portion of that foramen magnum. Okay. And this intense signal is going to be the vertebral coming together to form the bacilla in the midline. And while we're here, this is actually quite nice. Didn't mean to rotate that. So we can make out the superior sagittal sinus, the inferior sagittal sinus, the straight sinus, and remember that vein that drained into the straight sinus, that great cerebral vein of Galen. And there were two veins that contributed to that. The internal cerebral vein that was in the midline, kind of sitting above the third ventricle, and laterally going around the midbrain is the basal vein. We can make out here the proximate position of the corpus callosum. Okay, let's go laterally again and work our way anteriorly, looking at some more bony foramina in this middle cranial fossa. Okay, so we have, again, that condyle or head of mandible in the mandibular fossa of the temporal bone. Now, the most laterally located foramen in that middle cranial fossa is going to be Foramen Spinosum. That's quite small. I think that's it just there. Foramen Spinosum, and then immediately in front of, or anterior and medial to that, is going to be Foramen Ovale. Okay, so Foramen Spinosum, Foramen Ovale. And again, we can see that internal carotid coursing through the petrous temporal bone. As we proceed anteriorly, or as we proceed medially, situated anterior to Foramen Ovale, it's going to be Foramen Rotundum. So here we can see Foramen Rotundum, and this is the infraorbital fissure, or inferior orbital fissure. Or actually, here is the infraorbital fissure. What we're looking at is the pterygopalatine fossa. Okay. Progressing more medially still, we've got superior orbital fissure coming to a close here. And more medially still, that optic canal you can follow through here. So we've got the carotid siphon. If this is the pituitary, then we can appreciate the close proximity of that to the optic chiasm and optic nerve going through this optic canal. All right, so what we can also do is look at a coronal series. So I need a sagittal here. All right, starting anteriorly. So we're working our way through. We can appreciate that falx cerebri, crista galli, either side of which is going to be the cribriform plate. You can see that crista galli, actually, sorry. So this would have been the frontal crest of the frontal bone, and then the crista galli with the cribriform plate either side. So we have the olfactory bulb sitting on top of here. Moving posteriorly, we can make out the extraocular muscles and the optic, or actually, sorry, that's the ophthalmic artery. So at this level, you can start to appreciate those lesser wings of the sphenoid and the greater wings. And we've got inferior orbital fissure, superior orbital fissure, and optic canals. As we've got sphenoid sinus, giving rise to clivus, and the dorsum sellae. So we're looking at the posterior wall of the sella turcica, or hypophyseal fossa. Okay, but moving back anteriorly again, because we missed some nice bony prominences. Okay. So inferior orbital fissure, pterygopalatine fossa, and then we can make out our foramen rotundum. And down here, I'm going to be expecting foramen ovale. That looks like it. You might even see Foramen Spinosum. Okay, so Foramen Lacerum here, we can see the internal carotid sitting on top of it. I think that's actually Foramen Ovale. Foramen Spinosum here. And we can follow the course. No, let's just keep on going. Moving posteriorly. Okay. So here we have the external opening of the carotid canal. We can see that internal carotid coursing through petrous temporal bone. So it's external opening here. And again, immediately posterior to that, I'm going to be expecting the jugular foramen. So here's that internal jugular entering the skull, or rather exiting the skull as the sigmoid sinus, also in close proximity to the external auditory meatus. That's why we can sometimes hear the pulse in our ears, very close proximity of the eardrum with the internal carotid artery. All right, progressing posteriorly still. Jugular foramen. Actually, that's internal auditory meatus. So we've worked our way anteriorly. This is the internal jugular vein and the carotid external opening of the carotid canal. And as we go posteriorly, there's our internal auditory meatus. You can also make out the hypoglossal canal through here, above Foramen Magnum. All right. And then lastly, let's go over an axial. So as we make our way down, and I think we can even appreciate superior sagittal sinus, the falx cerebri, we've got that corpus callosum, lateral ventricles, choroid plexus within the lateral ventricles. We have head of the caudate here in the lateral wall of the lateral ventricle. And then frontal sinuses, frontal crest, orbital plate of the frontal bone. So now we're looking in the orbital cavity here. Cristogali and cribriform plate. And now as we make our way down, we've got optic canal, superior orbital fissure. Pituitary fossa, sella turcica, with the internal carotid working its way around. We're starting to look at those mastoid air cells in the internal ear. And so there's our internal auditory meatus. You can see the course of the internal carotid through the petrous temporal bone here. External auditory meatus with jugular foramen. That large jugular foramen there. Okay, back into the middle cranial fossa. We've got foramen rotundum, foramen ovale, and spinosum. And where's that lacerum? If we look down here, we can appreciate foramen lacerum either side of this basilar part of the occipital bone. Heading towards that hypoglossal canal. And then we can see the Foramen Magnum. And the cool thing about these as well, this is a little bit tricky to manipulate, We can generate 3D skulls. To get rid of these bookmarks, we can not only do that, but we can make clip plane move that clip plane around. Very good. So we can appreciate superior sagittal sinus, confluence of the sinuses, the straight sinus, transverse sinus, great cerebral vein of Galen, and we can also enable a little slab so that we don't have too much signal. Okay, so Foramen Magnum here. Upper Basal Canal, we can see the condyle of the mandible. Superior orbital fissure. As we come more medially, we've got that optic canal, pituitary fossa, foramen lacerum down here, foramen ovale, and then spinosum. But perhaps this 3D is better suited to some other cases. 20 minutes through, not too bad. All right, so let's go to this one. What we can do is generate an MPR again. Okay, so if we're looking on the axial scan as we go through, we can make out, this is quite nice here, as we get to the very start, we can see the sagittal suture, coronal suture, a very faint signal for that falx cerebri. Then we make our way into the frontal sinus. You can see we've got a fracture there. Fracture of that frontal sinus. There's a bit of bone in the orbit. We continue down. Zygomatic arch. This is going to be that head of mandible. This here, we've got the ramus of the mandible, coronoid process, condylar process, and we've got a fracture of that condyle of the mandible. We've got those maxillary teeth we can see. And look, we've got an air-filled maxillary sinus on one side, but it's occupied on the opposite side. So we've got bleeding into that maxillary sinus. Okay. So as we work our way down, this signal, because they've been intubated, and we can make out a pretty considerable fracture of that mandible. Okay. If we look at the coronal view, and here, look at that condyle of the mandible, pretty considerably fractured. Working our way anteriorly. You can see the disconnect between the maxillary and mandibular teeth. These fractures in the frontal sinus, in that superior orbital brim. And here. All right, so this is probably better suited to viewing in 3D, so we can get appreciation for these. So pretty considerable fracture to the frontal sinus. Appreciate that mandibular fracture. And we do have a maxillary fracture here, accounting for the bleeding in that maxillary sinus. Okay, let's see what we can see with a clip plane. We can also add some soft tissues. You can see an air-filled sinus, occupied sinus. That fracture of the body of the mandible, working our way posteriorly, coronoid process, and then that fractured condylar process. Okay. You can also use these to get a better appreciation of some of our brain tissue. So let's take a look at a nice MRI. So this one's pretty interesting because these particular scans are uploaded publicly onto the software platform called Sectra. But when they need to be anonymized. So a lot of the signal around the facial structures is deliberately deformed so that you can't identify it. That has potential to disrupt, your appreciation of the anatomy. So this scan is a 7 Tesla MRI out of the University of Colorado, and it was actually undertaken on someone who teaches anatomy or medicine at the University of Colorado, and because she volunteered, they didn't anonymize her face, or she deliberately did it so that they wouldn't anonymize her face. But on the flip side, it means that we've got a very nice undisturbed image of these brain structures. So let's pull up our NPR again. And since we were talking about imaging that lateral amygdala and hippocampus on the coronal, let's start looking on the coronal. Anterior, but 2 anterior here. And this is where we want to be. All right, so as we proceed posteriorly, this signal intensity is going to be branches of that anterior cerebral artery. You can see the superior sagittal sinus, falx cerebri, and we're just about to appreciate the most anterior portion of that corpus callosum. This is the genu. Okay. First part, or the frontal horn, anterior horn of the lateral ventricle. Let's just play around a little bit because the planes aren't perfect. Is that? That's a little bit better. Okay, so in the lateral wall of the lateral ventricle is our caudate. Here we can appreciate the rostrum. So remember how, let's take a sagittal view here. Remember the body, genu, and the rostrum of that corpus, splenium posteriorly. Okay, so we can see that rostrum here. We can also make out the internal capsule with the putamen. So the internal capsule, let's take a look at the axial view. If we can blow this one up, let's just pop him on there. Remember that internal capsule has a V shape. So it has an anterior limb, genu or bend, and a posterior limb. So what we're looking at in that coronal is the anterior limb of the internal capsule. With a small portion of that rostrum. Putamen getting larger. Appreciate the lateral sulcus with branches of the MCA. Also got that internal carotid snaking its way out. So this is above the foramen lacerum here. So we've got its cavernous portion. We've got the optic chiasm visible underneath the hippocampus. We follow those optic nerves anteriorly. But if we go posteriorly, you can see the formation of the anterior cerebral arteries. MCA diving laterally in that lateral sulcus. And in fact, from that MCA, first branches we can see are those lenticulostriate branches, okay, immediately going superior to supply the lentiform nucleus and the striatum. So at this point, we've got putamen laterally, and we've got a nice distinguished lighter appearance of the Globus Pallidus. And we see these transversely oriented fibers. It's the anterior commissure, okay, above the third ventricle, which we can see. So at this point, we've got optic tracts, third ventricle. So if we pull anteriorly, you can see how we've got this communication there. What we're actually looking at is the two anterior recesses of the third ventricle. So remember, there was a recess associated with the pituitary stalk or infundibulum and a supraoptic recess. So we've got optic chiasm, supraoptic recess, infundibular recess. So if we pull anteriorly, you can see that infundibulum give rise to the pituitary. Okay. Third ventricle again. So we're hitting Gen U of internal capsule here, which means that we're about to see thalamus. So if you look in the bottom left, after the Gen U, we're going to pick up some thalamus. Corpus callosum, we're looking at its body here, and this midline structure between the two lateral ventricles is that septum pellucidum, that semi-transparent, semi-lucid, or pellucid septum separating the lateral ventricles. And if we look back at our sagittal, the septum pellucidum runs from the corpus callosum to that fornix. Remember that white matter structure associated with the limbic system? Okay, we're going to proceed posteriorly. Anterior commissure. And we can see where this fornix is diving either side of the midline around the third ventricle. So here's that fornix, and if we dive lateral, then what we're seeing is that fornix descend lateral to the third ventricle to span to this collection of nuclei of part of the hypothalamus called the mammillary bodies. So we can follow this white line going from the mammillary bodies either side of the third ventricle, and that is the fornix. And we're looking at this inferior horn of the lateral ventricle now. Let's dive into that. So we've got the inferior horn itself, located inferiorly and medial to it, or in this instance a little bit lateral, is the hippocampus. But superior to it is the amygdala. So whenever we can find that inferior horn of the lateral ventricle, the hippocampus is going to be below it, the amygdala is going to be above it. I know that was a particular question we had. Okay, moving posteriorly. So now, lateral ventricles, septum pellucidum, fornix, and we've got our interventricular foramen, draining the paired lateral ventricles into the third. You can see the shape of the lateral the hippocampus a little bit more clearly now. And we've also got these two vascular structures and the basis of the pons here. So if we work our way anteriorly again, we can see that the vertebral artery is coming together to form the bacilla. And these paired blood vessels are the terminal bifurcation of the bacilla into the posterior cerebral, immediately inferior to which, or proximal, if we're considering from the bacilla's origin to its termination, proximal to the bifurcation is the superior cerebellum. Now, between those two blood vessels, this signal intensity in here is the oculomotor nerve. So the oculomotor nerve, the third cranial nerve, can be found between the posterior cerebral and the superior cerebellum. And it can potentially be impaired by aneurysms, aneurysms at that terminal bacillar artery. And so again, looking closely, inferior horn, lateral ventricle, hippocampus, amygdala, putamen, and globus pallidus, internal capsule, body of caudate. Okay, so we've got the insular cortex, the lateral sulcus, and this frontal or parietal operculum, and the temporal operculum. There's little lids. All right, proceeding posteriorly. So we've got those mammillary bodies just here, and then they give rise to the interpeduncular fossa. So now we're looking at the cerebral peduncles and the thalamus. Caudate thinning out. You can see those small cellular bridges even in the posterior limb of the internal capsule. At this level, we'd have the substantia nigra and subthalamic nucleus immediately above it. Okay, those fornices come together, attach to the splenium of the corpus, and then separate from one another to go into their respective inferior horns of the lateral ventricle. So there we can see medially, we've got the fornix, and in the lateral wall of the lateral ventricle, this is going to be the tail of the caudate as it swoops posteriorly around. So let's see if we can't see that on a sagittal. Okay, so here's our fornix. We can follow this fornix as we extend laterally. Finally, in the lateral horn of the lateral ventricle as it gives rise to the hippocampus. But what we can also see is the head of the caudate, body of the caudate, moving laterally, and it's very thin at this point, but found superior to that inferior horn. And this is kind of illustrating that point about the hippocampus as well. Here we have the cavity of the inferior horn of the lateral ventricle, hippocampus inferior to it, and the amygdala superior and more anterior. Okay, let's circle back again. Starting with the thalamus again, substantia nigra, third ventricle, and what we have, can we make them out? Not quite. Okay, I just need to sneeze. No. False alarm. All right. I was seeing if we could make out the pineal and suprapineal recesses on the coronal. That's going to be quite difficult, but we can appreciate them on the sagittal. So here is our pineal gland, immediately anterior to which is it's kind of attached. If we go from the pineal to the tectum, the connecting structure is the posterior commissure. Let's work our way down. There's our pineal, and then that anterior white matter structure is the posterior commissure here. But we can't make out those suprapineal and pineal recesses on the corona. It's quite difficult. All right, so at this point, these four lumps that we can see on the posterior aspect of the midbrain are the colliculi, superior and inferior colliculi. And the structure here is the superior cerebellar peduncle, which is going to be that output, working superiorly. And as we make our way a little bit more anteriorly, so we can assess some more of those brainstem structures, and we can see pons and the middle cerebellar peduncle. As we work our way anteriorly, you can see at that pontomedullary junction, we've got cranial nerves emerging here, so possibly facial, possibly vestibulocochlear. You can make out the inferior olivary nucleus, that bulge laterally. And then as we make our way more anteriorly, the only structures we're going to see in the medulla are those pyramids, medullary pyramids with that midline anteromedian sulcus or fissure. Okay. And also make out somewhat the trigeminal nerve. So as we come anteriorly, this structure here is the trigeminal nerve. Okay. But what else can we see? So immediately inferior to the middle cerebellar peduncle is going to be the flocculus of the cerebellum. And it's the flocculus, the middle cerebellar peduncle, and we can see these glossopharyngeal and vagus nerve fibers quite nicely on the other side. But it's this area here that is that cerebellopontine angle, where we're quite susceptible to vestibular schwannomas or acoustic neuromas, as they're called. And I only found out yesterday. It was a shame that I didn't find out before the lecture on the brain. We were looking at the anatomy, but Mark Ruffalo actually had a vestibular schwannoma, acoustic neuroma. So he experienced loss of hearing and some partial facial paralysis because of the denervation of the temporary effect on his vestibulocochlear and facial nerves. Pretty cardinal symptoms of the acoustic neuroma. Right, so flocculus, and also with that flocculus, associated with the flocculus, is the lateral aperture of the fourth ventricle. Lateral aperture of the fourth ventricle here. See that median aperture between this more inferiorly located part of the cerebellar vermis, rather, not the tonsil. But yeah, so circling back to these glossopharyngeal and vagus nerve fibers. So whenever we need to distinguish between them, like at this point, and this is going to be very tricky, but if we follow these back, we've got a lot of nerves arising from that cerebellopontine angle. But we can make out some that are going upwards and some that are going downwards or horizontally. So these that are climbing are going to be facial and vestibulocochlear as they ascend to get into that internal auditory meatus, whereas these more horizontally located are going to be glossopharyngeal and vagus. And as we look inferiorly, we can potentially even make out this here is going to be the spinal accessory nerve. Now, I would be very surprised if this was the level to which they're testing, because it took me a while looking at these images before I was somewhat confident to say that that's what we're looking at here. Certainly on a still, I don't know whether I'd be able to do it. Okay, let's take a look out and look more posteriorly. Okay, so what we're looking at is that pica, that posterior inferior cerebellar artery associated with the cerebellar tonsil here. We've got the fourth ventricle we can make out, and if we follow this part of the fourth ventricle as we go anteriorly, you can see this lateral aperture, this lateral recess associated with the flocculus. Okay. Got the vermis of the cerebellum. Splenium here of the corpus callosum with some choroid plexus in the lateral ventricle. And as we go more posteriorly, then we have this sulcus on the medial surface of the occipital lobe. Okay, kind of located in a transverse. Whoa, I did not mean to do that. Let's take a look here. So we've got going down is that calcarine sulcus. Recall that that separates the primary visual cortex into upper and lower banks. We also have kind of perpendicular to it the parieto-occipital sulcus. So parieto-occipital calcarine. Okay. More posteriorly still until we hit the end, and we can make out that superior sagittal coming transverse from the confluence of the sinuses, and a very small occipital sulcus in that falx cerebelli. Okay, so let's have a look on the sagittal. And we'll pull out of here. We probably want a coronal image to provide us some reference, and make this a little bit smaller. Oh. Okay, yep. All right, so midline. Let's try and get that. Hang on, midline. That's a little bit better. All right, so corpus, body, genu, rostrum and splenium, fornix, lateral ventricle with the septum pellucidum. Zoom in a little bit here. We've got basilar artery, quite readily apparent pontomedullary junction. Optic chiasm. There we go. So suprachiasmatic recess, infundibular recess of the third ventricle associated with the pituitary gland and infundibulum. Posterior to that is the mammillary body. The thalamus located here. As we see, we've got pineal gland, posterior commissure, superior and inferior colliculi, and we can see the pineal recess and suprapineal recess a little bit clearly, or more clearly here. All right. Anterior cerebral arteries coursing above the corpus callosum. Recall that cingulate gyrus immediately above the corpus. Tentorium cerebelli, and this here is that great cerebral vein of Galen. So internal cerebral vein going up, and then lateral, of course, the basal vein. All right. So as we proceed laterally, first thing we're going to find in that lateral wall of the lateral ventricle is the corpus, sorry, the caudate, head of the caudate. Okay, as we continue laterally, we're going to find anterior limb of internal capsule, separating the caudate from the putamen. Here we're approximately at the genu of the, we can see the genu of the internal capsule, thalamus, and we can also make out the posterior cerebral artery and the superior cerebellar artery just inferior to it. Okay. I've already looked at the course of the fornix as it goes around this part of the thalamus. There's our hippocampus and amygdala, putamen, giving rise to insular cortex and that lateral sulcus. And let's look at the brainstem. Whoa! Starting laterally. So we've got cerebellar hemisphere, tentorium cerebelli. See that vertebral artery. And bacilla. So we've got cerebellar tonsil. You can make out the fourth ventricle, and as we dive laterally, that lateral aperture, lateral to the medulla, with that flocculus here. Okay. Going towards the midline. The superior medullary velum with the superior cerebellar peduncle, superior and inferior colliculus. And if we're looking at that midline, and let's dive into, whoa, it's a bit enthusiastic. So we probably have here the gracile fasciculus, gracile tubercle, and a very small and very faint central canal of the spinal cord. So that fourth ventricle exiting by the median aperture, but also draining or becoming continuous with the central canal of the spinal cord. There, we can make out an olive there, inferior cerebellar peduncle. And this here, as we go from medial to lateral, you can see the course of the oculomotor nerve between the posterior cerebral and the superior cerebellar artery, eventually diving into that cavernous sinus lateral to the internal carotid. Perhaps not too much more we can make out on this. Let's dive, let's look at an axial. Sagittal there. Starting from the top. Okay. Lateral ventricles separated by septum pellucidum, caudate in the lateral wall of the lateral ventricle. You can make out fornix, thalamus, putamen, internal capsule, genu, and splenium of corpus callosum here, insular cortex, central sulcus, Globus Pallidus, anterior commissure here, choroid plexus in the lateral ventricles. Posterior commissure here, pineal gland. And then optic tracts, mammillary bodies, cerebral peduncles, substantia nigra posterior to that. And we've got our collicula, probably superior colliculus here with the the cerebral aqueduct. Infundibular recess there. Optic chiasm and optic nerves. And you can make out a little bit of those oculomotor nerves coming through. We're starting to appreciate that tentorial incisura, so the opening in the tentorium, getting a little bit of the midline cerebellum here, so the top part of the vermis. We've got the inferior horn of the lateral ventricle, amygdala anteriorly, and hippocampus. So looking at the upper portion of the pons here. Basilar sulcus occupied by the basilar artery. These fine fibers, can we see? Oh, perhaps not. Yeah, this is what I want to see. Okay, so more laterally, we've got the origin of the trigeminal nerve. Generally above or at the upper portion of the middle cerebellar peduncle. So here we've got big middle cerebellar peduncle. As we ascend from that, as it starts to diminish, we can see the trigeminal nerve into fourth ventricle proper, approaching pontomedullary junction. And this is what I want to see. This structure here, again, quite a level I would anticipate beyond what we're pushing you to, but that there is the abducens nerve. So the abducens nerve arising at the pontomedullary junction in the midline, ascending either side of the basilar artery, and then diving into the cavernous sinus from behind. That there, so we're looking at it originate from the pontomedullary junction, and as we climb up, you can see the abducens. So because it's between the basilar, or the basis of the pons, and the clivus, it can be quite susceptible to damage during whiplash injury if the hind brain and the contents of that posterior cranial fossa push anteriorly. Okay, we can also make out facial and vestibular cochlear nerves. Okay, so again, pons, trigeminal nerve, abducens nerve, and here we have facial and vestibular cochlea. This hyperintensity is a blood vessel associated with the internal ear, or the inner ear, called the Labyrinthine Artery. It supplies the bony and membranous labyrinth that comprise the inner ear. Okay. This here is that anterior and medial course of the internal carotid through the petrous temporal bone. Probably said that enough times. As we track inferiorly, we're going to start to see glossopharyngeal and vagus nerve fibers. Here we are, glossopharyngeal and vagus. So now we're in the medulla. So we've got anteromedian sulcus, either side of which we can see the pyramids, pre-olivary sulcus, post-olivary sulcus. These join as the anterolateral sulcus below the level of the olive. And between the pyramid and the olive, we might catch some hypoglossal nerve fibers. Probably closer to that pontomedullary junction. There it is. pyramid and olive, but we can see it above that. Okay. Glossopharyngeal and vagus, and then if we keep on going down, there's our jugular foramen associated with the internal carotid. This is probably its cervical portion. Hasn't yet entered the skull, and now it has. There's the jugular foramen, glossopharyngeal and vagus. And as we go inferiorly, you might see a little bit of, actually no, that's going superiorly. You might see a little bit of that spinal accessory nerve, not quite. Okay. Zooming out. And coming up. All right, so fourth ventricle, and then we can see here, they're lateral apertures. The lateral apertures of the fourth ventricle. And then immediately superior to that is going to be the flocculus. Above that is our cerebellopontine angle. Okay. And then vertebral arteries inside the dura and the extradural portion as it's looping over that C1 and then continuing forth. Going in reverse, so this is its ascending portion through the transverse foramina. You can make out the dens of the C2 and that anterior arch of C1. Okay, that was pretty exhaustive, but I don't know how you guys found it, but I find that dynamic approach or using these dynamic images really useful. So we're just over an hour through. Let's take a look at a flare image, a flare series. Is this the flare? No, that's not a flare. Where's my flare? There. Okay, so let me get the MPR again, and I'll get rid of you. I'd very much like to sorry, while I work this out, you one by one. You okay, and now we can go to the NPR. All right. So much the same, but we've got a pretty, that's actually really nice to see those facial and vestibular cochlear nerves, not super high res, but that signal intensity, now that we've attenuated the cerebrospinal fluid, it's quite nice. So if let's work our way up. So, basis of pons, there's that trigeminal nerve, facial and vestibular cochlea, and we can make out this little hyperintensity here, separate to the pons itself. That's the Abducens nerve. You've got glossopharyngeal and vagus. There's our hypoglossal. Cool. And let's look at that sagittal, coronal. All right, so nice Oculomotor nerve, going anteriorly here from the midbrain. Remember, that arises between the cerebral peduncles in that interpeduncular fossa. You can see this little signal intensity climbing up as the abducens. Trochlea is going to be, I would guess, impossible to see just because of how small it is, originating posterior on the midbrain, beneath the level of the inferior colliculus. Let's go laterally. There's that lateral aperture of the fourth ventricle. And here, facial and vestibular cochlear nerves going into the internal auditory meatus. As we go back to this pontomedullary junction and start to look for our vagus and glossopharyngeal. That's then associated with that jugular canal, jugular foramen rather. So again, pretty difficult to see those cranial nerves in a lot of instances. What about an axe? Oh no, we did that. Let's go coronal. It's a nice view of the putamen and globus pallidus, third ventricle. Internal capsule, really nice. Working our way more anteriorly here and posteriorly now. So rostrum and genu of corpus with the septum pellucidum between them, and then eventually the fornix. Okay, insular cortex, hippocampus and amygdala, substantia nigra and thalamus. So a really nice view of that facial and vestibular cochlea. And glossopharyngeal and vagus. Oh, no, maybe not. Glossopharyngeal and vagus. Perhaps spinal accessory coming up here. There we go, that's them. Glossopharyngeal vagus. All right, so now let's take a look at some pathology. This one isn't going to be terribly subtle. Monitor partition one by one. Show me this. NPR. Okay, so straight away, looks like there's a little bit of midline shift. Got lateral ventricle, but it's pretty much occluded on the contralateral side. And we've got this very large cerebral hemorrhage. So not only is that bleed obviously losing or causing damage to the brain structures here, we've got an arterial bleed, so high pressure. It's acting as an intracranial mass lesion, and it's moving brain structures, particularly against this falx cerebri. So recall that the anterior cerebral artery, if we look at that mid-sagittal, are we going to get a good view of that? Recall that the anterior cerebral courses above the corpus callosum, and it is the two anterior cerebral arteries are separated from one another by that falx cerebri. So if we have a mass effect lesion on one side, it can potentially push the medial surface of the brain against the falx cerebri, occluding the anterior cerebral artery. But suffice to say, a very large infarct primarily. So let's look laterally here. Let's get that sagittal. Okay. So there's our lateral sulcus. So this is involving that superior temporal gyrus. Okay. At least. So they're probably going to have some considerable language deficits, particularly if this is on the left-hand side. So Broca's area, Wernicke's area. Okay, so primarily that MCA territory we're looking at. All right. And then we saw it on the axial, about the coronal. Going posteriorly, cerebral lesion involving the temporal, frontal and parietal lobes, so classic MCA territory. Okay. What do we want to look at here? We saw the facial fracture, saw that one. What about, oh, actually, I think, is this one? Yeah, here we go. So a nice little reconstruction of arterial network. Vertebrals coming together to form bacilla, so we can even appreciate on this scan how it looks like there's a left dominance to that vertebral supply of bacilla. Okay. Internal carotids, cerebral portion, petrous portion, cavernous portion, carotid siphon, that clinoid process, that anterior clinoid process above or between that kind of U-bend, becoming continuous with the anterior cerebral, middle cerebral, giving off the anterior cerebral, and we can make out the bacilla's terminal bifurcation into the posterior cerebral with, if we play with that a little bit and dive into there, I can just make out that superior cerebellar artery. The posterior cerebral hugging that inferior and medial surface of the temporal and occipital lobes. Zoom out a little bit. See a nice view of the anterior cerebral above, or it's arching over the corpus callosum. And if we separate those, we can get an appreciation for what I was saying before with that falx cerebri in between the anterior cerebral arteries. If there's any mass effect lesion, that can potentially block that artery. So in that instance, we might have a bleed when we're looking back at that cerebral hemorrhage. A hemorrhagic stroke could potentially cause an ischemic event in a different vascular territory. And we've got, can we see those lenticular striate arteries? Too much. Okay, but MCA giving off those lenticular striates. You can't see them just yet, but it's going to be found, the MCA, in that lateral sulcus, overlying the insular cortex, and then eventually ascending branches over the frontal and parietal lobe and descending branches over that temporal lobe. All right, we can even make out, that's going to be like superficial temporal, but is this here an epidural artery? I can't say for sure. Okay. But a nice little vascular view. And we can also make out pardon me. So vertebral, right vertebral, left vertebral, and this is pica, posterior inferior cerebellar artery, and arising off that vertebral. And the left pica visible here as well. All right, let's get into the spine. And let's sew in here. Okay, so we've got intervertebral disc, outer annulus fibrosus, inner nucleus pulposus. We've got the spinal canal. And so the hyperintensity will be a combination of probably our epidural fat, the hypointensity, epidural veins. You can make out that spinal cord. So we've got spinous process lamina here. And we would, on a sagittal, be able to see that ligamentum flavum associated with the laminae. Anterior longitudinal and posterior longitudinal. The vertebral body and pedicle here. Now we're looking at that intervertebral foramen, which is where our spinal nerves are going to emerge. We'll find the dorsal root ganglion in that intervertebral foramen. Let's jump on this sagittal view. So remember that anterior and posterior longitudinal both being that hypo-intense signal anterior and posterior to the vertebral bodies respectively. And then we've got a hypo-intense signal associated with that laminae. You might make out the pedicle here. As we move more medially, that's giving rise to spinal canal, epidural fat, and then we've got cerebrospinal fluid, conus medullaris, spinal cord, and what we were just looking at, same again, looks like. The vertebral discs. All right, well, actually that was faster than I thought. Did you guys have any questions? Was there anything more you wanted to see on any of the scans, any of the modalities? We're happy to play around. So we had the CT skull where we can look at bony foramen, had the MRI, 7 Tesla and the T2 flare. Are there any questions? Because this is the last we've got on CNS. On Friday, we're going to be looking at head and neck. Substantia nigra and subthalamic nuclei on axial MRI. Let's see what we can see. NPR, and we want to jump on. Are there any websites that give 3D views of various anatomy. Pop, pop, pop. So I can't attest to three-dimensional anatomy. I think any kind of application that will run that will probably have to pay for. And far be it from me to tell you to go and buy anything. But there are some 3D models. Sketchfab. So if you guys check out Sketchfab, and that's where I got the 3D model that was included in the second PowerPoint. That's where I got that from, and I will embed that 3D model into the course materials folder. But if you have a look on there, there's going to be a bunch of 3D models that you guys can play around with. Let's take a look. Okay, so I think it's going to be quite difficult to see subthalamic nucleus on axial MRIs. That being said, we can kind of infer its position, because what we've got here is a nice upper midbrain. So the interpeduncular fossa, we've got a little bit of that oculomotor nerve, cerebral peduncles, and cerebral aqueduct. So I would say that this here is going to be the approximate position of substantia nigra. Okay. It's not popping as it would on a cadaveric specimen because it's neuromelanin isn't going to make it look that much more distinguished or more discernible on an MRI. But as we climb up, that's the wrong way, as we climb up, then again we would be giving an approximation or just, okay, so we've got mammillary bodies. So perhaps I could say this would be the approximate position of the subthalamic nucleus, but identifying it visibly by any cues in here is, if it can be done, it's beyond my skill. Let's just say that. Yeah, I would probably just be using cues such as the fact that, all right, so we've got optic tract, infundibular recess, mammillary bodies, into the interpeduncular fossa, and just be having a guess that this would be where the subthalamic nucleus is. Yeah. Substantia nigra is probably a little bit more straightforward because you can somewhat see the difference between, I wonder if I play with these, whether that'll make that pop a little bit more. And maybe see the difference between the white matter of the cerebral peduncle and substantia nigra a bit more clearly. But there's just a lot of, or there would be a lot of clues from surrounding brain structures, is what I would say. You guys have any other questions? Kind of came to a somewhat anticlimactic finish, but I don't know. How did you guys like that? What was your experience of that? You know, I'm not fishing for compliments, but this is the first time I've done this, so I'm just, as far as a practical, in inverted commas, experience and looking at these dynamic experience, albeit not driving it yourselves, was that any more useful, or were you able to integrate some knowledge from the 2D scans? It's great to hear. Well, we'll be doing this again for head and neck for sure. I think knee I'll have to look at the timetable again, but I think the knee might just be a single lecture. Yeah, a single lecture where we do the anatomy and the thing. That's my kind of estimate of it as well. I think this tool is really great. Like looking at these dynamic images is amazing. Either if you already have a pretty good anatomical knowledge, or if there's someone there to kind of tell you what you're looking at. Otherwise, it's kind of being led by the blind. All right, well, my job's get this up. Again, I'll hope to get the recording up by, let's say, 5 p.m. tomorrow. So if it gets to Friday morning and it's still not up, then let me know. And my other job is to embed a 3D model into course materials. I also need to get the lecture slides, the PDF, up to you, but still making some last minute changes to that. So again, if it's not up by 5 p.m. tomorrow, then that means I might be able to, or might need reminding. All right, well, if there are no more questions, if there's no more structures you guys want to see, then let's all wrap up. It's 6:30, so that's time enough. Let's stop share. And turn on the camera. Alrighty, job done. Let's see you Friday for head and neck. No worries.